pleasure to introduce the newest member of our staff at Capitol Hill Village, our Director of Care Services, Liz Gregg. She is a licensed clinical social worker with deep experience working with older adults, and has taken her interest in end-of-life issues into the study of becoming a death doula. So she's going to be speaking to us about hospice, about palliative care, and I think getting into some of the details, some of the detailed questions that many of you had. And this session too will be followed up with a Q&A. So please put questions in the chat or raise your hand, and I'm going to turn it over to Liz.
Great, thanks so much. I do want to just double check that our organizers are going to record this, because I've had a couple people say to me that they could not be present and wanted to hear my comments. So great, I see it's recording. Thanks so much. So again, introducing myself, my name is Liz Gregg. I'm a clinical social worker. I want to start by thanking our incredible organizers for this event. We've had several key members of the Capitol Hill Village who have provided hours of work to shape our agenda, and I think have done a remarkable job. Our prior presenters were outstanding. I also want to give a little shout out to my friend and colleague, Dixcy. I always learn something from Dixcy. Dixcy and I have known each other since our children were very, very young. So we share a lot, not only family, a school that we overlapped in, but also our chosen professions and our extreme interest in death activism. I also want to just let everybody know I've lived on Capitol Hill since 1997. I've raised my 3 boys into young men. They've attended charter schools and public schools. And I've been a social worker since 1994. In that time, I've worked on a large variety of issues, including chronic mental health disorders, substance abuse, drug addiction, homelessness, but my real passion has been working with adults aging in place and the challenges that both seniors and adults with disabilities face in doing so safely and with dignity. So it's been really just a highlight of my career to come to the Capitol Hill Village. I'm constantly impressed in the last few months by the engagement, the inquiry, the curiosity that the members bring, and by the quality of staff. So I'm thrilled that I am here presenting to you on one of my favorite topics. And just to specify, Judy was kind enough to mention that I am a trained death doula. Many people don't know what that is, and I'd like to just sort of bring that to the forefront. Some of you may have heard of a birth doula, and in the same way that birth is a passage into life, death is a passage out of life. And doulas can serve by having the capacity to really sum up and plan with an individual about their life and about their wishes, working both individually with partners and with family. It can be a process that can be started well before death. Many people start it when they're given a terminal diagnosis, whether they have, a month or 6 months to live, but it certainly can be started at any point as you begin to plan the kind of death you'd like to have. Oftentimes, many people choose to engage in some kind of a final project, a legacy project, whether it is words, art, bringing together a variety of resources from their own life, a scrapbook, photographs, summing up their own words about their, for example, an informal memoir. So sometimes people choose to work with a doula during the process of deciding what kind of death they'd like to have on some kind of summative project. People typically think of that as a question and answer and videotaped, and that is one option as well. Finally, not finally, but also at the time of death, impending death, Doulas oftentimes can sit vigil. They can be a resource both to the person who's dying as well as family and friends who are coming through, helping to create and shape the environment that the person who's dying and their family wants. So actually being there for the days or hours leading up to death and dying, helping in that early stage of grief, helping with planning and allowing family to, once again, check in about the wishes of the person who has died, creating an experience after death that includes acknowledging grief, celebrating the life that has passed, and then helping to begin that process of long-term grieving and referring out to other resources as needed. So I had a couple of people ask me, what's a death doula? So I really just wanted to take a couple minutes out of our presentation to share what that is. And I have not served formally and solo as a death doula, but I integrate that work all the time in my work as a clinical social worker. So thank you for allowing me to say that. And I've also completed the coursework for an end of life certificate that is an additional credential in addition to being a licensed clinical social worker. So the focus of my presentation today is regarding the difference and the similarities between, palliative care and hospice care. Oftentimes they're used interchangeably, and yet they are not interchangeable. It's a Venn diagram. There are areas that are very distinctly hospice care, areas that are very distinctly palliative care, and then overlap. And so I'm really going to break that down over the course of the next 20 minutes or so, allow for some questions and answers. And of course, you'll have more opportunity in the breakout room to discuss your thoughts regarding that. So I think the easiest way to convey this is really to talk about differences and similarities. And I decided I'm going to do a compare and contrast instead of talking about one model and the other model. So for those of you who are taking notes, you may literally want to put a column down the middle of your paper and put a heading palliative care on one side and a heading hospice care on the other side. That may help you keep track of this as we move between those. So in the beginning, I'll sort of start with the who, what, when, where, how kind of aspects to really keep it simple. And of course, in questions, I can get more detailed, but for many people, they're unclear enough that I want to start very simply. So the first thing I'm going to talk about is who can be treated for palliative care or hospice care, and who qualifies. So palliative care can be anyone with a serious illness, a chronic illness, someone who's been diagnosed with a chronic illness and is seeking management and relief of the symptoms, along with improved quality of life. So palliative care is really aimed toward increasing quality of life for someone with a serious illness or a chronic illness, okay? Separately, you may want to know, well, how is that different from hospice care? The folks who are treated in hospice care is anyone with a serious illness who usually two doctors both certify that they have a short time to live. It can be measured in months, not years. Oftentimes it's 6 months or less to the best of their capabilities. And so they need to be diagnosed with a terminal illness. And like people with palliative care, they are seeking the management and relief of the symptoms that go along with their condition and will lead to an improved quality of life for their remaining time. Okay. I'm going to go on to my next category. And this one is more similar than dissimilar. The way the other one had some overlap, it's the one about who can be treated and who qualifies. The similarity is it's about quality of life. It's about improving the time you have managing your illness. The difference is that hospice is for those who really, their life can be measured in months and not years. The next one is, will my symptoms be relieved? In other words, how will this work for me? And in palliative care, the idea is that although there may be a progression of the disease, the symptom management is going to be constructed by a team of medical professionals. Wow, having earplug problems. So the symptom management is going to be constructed in a manner by medical professionals. It should be holistic, looking at all aspects of your physical self. And it is aimed at reducing the symptoms related to your chronic disease, and again, improving your quality of life. Again, very similar overlap to hospice care. And so with hospice care, we know that the progression of the disease is also going to take symptom management. We recognize that reducing those symptoms will improve quality of life, but that life is going to stop short within a matter of months. And so palliative care is oftentimes for a longer focus. Hospice care does involve palliative care, but it's not intended to go on long term. Next, I want to share something that I think of as one of the main differences, which people may not realize, between palliative care and hospice care. In palliative care, people ask, well, I'm going to continue my treatment, and that is the case. You will continue to seek curative treatments. So whether it's a chronic illness, a long-term illness, an onset of an illness, in palliative care, you may continue to seek a cure in any manner that your medical team recommends and that you feel comfortable with. In hospice care, once that disease has been certified as terminal, in order to enter hospice care, you have to have determined that you are no longer going to pursue a cure. Curative care will not be part of hospice care. And so that's where the palliative aspect of hospice care shines. So we're not looking to cure you of your illness. We recognize that your condition is terminal in a matter of months. And so we're looking to manage your symptoms, improve your quality of life, and that you will not pursue any aggressive treatments toward aiming to cure you. Again, it is really aimed toward not cure, but managing quality of life, improving that. Finally, again, this is quite different in the different models. In palliative care, the needs of the chronically ill person fluctuate. Sometimes they can have bad phases or good phases. Sometimes palliative care can play a large role, sometimes a smaller role. But until there is a level of care met, you cannot enter hospice care. In other words, you can be indefinitely on palliative care, but when it is determined by your doctor or doctors that your life will cease in about 6 months or less than a year, in a matter of months, you may go ahead and pursue hospice care. And again, the shared aim of quality of life is predominant. You may be treated by a team of people. You might be treated by individual people in different settings: hospital, outpatient, inpatient, residential hospital settings, or in-home. All of these can be included in palliative care, but only some of them are reflected in hospice care. So again, to reiterate that, where can you get palliative care? You can get that care at home. from your doctor who prescribes you medication to relieve symptoms and increase your quality of life. You can get that in an assisted living facility by the physicians and medical practitioners there. You may get it in a nursing home at any stage. And finally, at a hospital, palliative care doctors are increasingly being seen in hospital settings because we recognize that if someone has a chronic illness and has been in the hospital for a while or in and out of the hospital, their quality of life is important to recognize and can be done through a palliative care plan. Separately, hospice care can be done in the home. Many people realize that it can be done in a hospice facility, and many people are very comfortable with that. They want a home-like setting, but they do want the infrastructure of a medical setting. They want to know that there are nurses, doctors, someone else be changing the sheets or taking their loved ones to the bathroom. They don't want to be left at home alone. And there are distinctive differences between the kinds of services in an residential hospice facility versus an in-home facility or in-home hospice care. Hospice care can also be, in some medical settings, offered in a hospital. It's unfortunately a very expensive model, and so hospitals don't like to keep people on because some insurance plans don't cover it, but it can be done. And same thing with nursing homes. In fact, just as a point of anecdote, my mother and my father, I was with both of them when they died, and it was truly my honor. My mother had battled cancer for 10 years, even though she was diagnosed with stage 4 cancer, which means it was metastatic, and she only had 6 months to live. And she decided that she was going to enter an experimental treatment, a protocol at NIH. And essentially that bought her about 10 years, even though she went in and out of treatment over those 10 years. But in the last few months, she made it very clear to my family, including my father, the kind of death she wanted. Unfortunately, my father could not hear it. And so in the end, despite the fact that we had set up arrangements to honor her wishes, I called hospice and got it started despite my father's objections and including my mother's blessing. And she was able to peacefully die at home the day hospice started. She was really at the end of her life. Hospice at home is not for everyone, and a death at home is not for everyone. And so it's something to keep in mind as that deterioration occurs, as mental and physical functioning decreases. Some people are more comfortable with some other setting beside the home. In terms of my father was living in assisted care and began to show an overall decline in his health. He went in and out of hospital settings as he had increasing infections, skin breakdown, urinary tract infections, swallowing problems. He was on a merry-go-round. And after the third time of going into the hospital for a week and coming out and having about 2 or 3 weeks of not a very good quality of life, I asked him, Dad, do you want to continue this? It's your life. You understand what lies ahead. You've done this 3 times before. It's been about 2 months you've been doing this. You look exhausted to me. What can we do to improve your quality of life? At that point, we talked about a variety of options, and he chose that the next time an infection occurred, if it could be treated with oral antibiotics, he would stay and he would go to the medical wing of his assisted care facility, but that he did not want transportation to the hospital. Fortunately, the medical team at the assisted care facility was wonderful, and they essentially set up a hospice-like setting in the medical area. They had a doctor on call, they had a standing order for morphine, and allowed my dad to be very comfortable as he got increasingly sick because the oral antibiotics next time around did not work. He again reiterated his wishes while he was still able to share them, that he did not want transport. He did not want resuscitation, etc. And so finally, as he was increasingly uncomfortable, but still just verbal enough to give consent, I asked him, and a nurse asked him, "Dad, would you like to have morphine now? You will probably not wake up again." And he was able to say yes and nod his head. And then he had his nurse ask the same question in front of the doctor. He was able to say yes and nod his head. He was given a final dose of morphine. I was with him, I held his hand, and he died very peacefully in his sleep. So these are kind of different experiences of a hospice-like death. But each of them involved palliative care. For my mom, who was in tremendous pain in the last few months of her life, it progressed from Percocet to other forms of powerful painkillers, finally to fentanyl patches. She did not like the fentanyl patches because she was not able to maintain her ability to be cognizant. She could not think, she could not speak, and she'd have just a few hours that she could tolerate the pain. When she came out of her fentanyl, it would take a couple of days, she'd get relief, she'd come out of it, have brief conversations, and it was in one of those breaks that she was able to say, "I don't care what your father wants, call hospice." And so that was a wonderful gift that she gave to me. I don't know how I'm doing at the time check. Let me just double check. Okay, got about 5 more minutes. So I want to give a quick summary again for those of you who have been taking notes or listening, the differences between palliative care and hospice care. So palliative care, the diagnosis should be serious, probably chronic, but not necessarily terminal. For hospice, that diagnosis is terminal, and it's made in months rather than in years. You can be referred to palliative care at any time. I have been referred to palliative care because I live with a chronic pain disorder. I have used a variety of different pain relief, and thank goodness right now I'm doing very well, but I have been referred to palliative care since I was 11 years old. They didn't call it then, but they do now. However, I would not be referred to hospice care until a doctor, or usually two, certifies that I'm usually within about 6 months of death. In terms of the treatment, again, palliative care is pain management, and you can combine it, should you wish, with any kind of curative treatment. So your pain, your quality of life is going to be addressed in palliative care, and you probably are seeking treatment to either reduce or eliminate the disease that you have been diagnosed with. In hospice care, you're being given pain management. We're looking at the quality of your life, but we are not, you are agreeing that you will not pursue curative treatment. And something subtle that Dixcy brought up that I'd like to share is, people say, well, how come my friend who was on hospice was getting chemotherapy? Well, your friend may have been getting chemotherapy because of the pain related to their cancer and trying to reduce that pain by reducing perhaps the size of whatever tumors there were. And so there is no sense that that kind of chemotherapy or other treatment is going to actually cause a cure. It's purely to increase quality of life. My mother, even in her end of life, she was getting ongoing chemotherapy because of the pain she was experiencing, but there was no sense of cure. There was not going to be a cure. So she was still in hospice care, but she was not able to have any sense that there would be a cure from it. Again, palliative care can be performed any place. It can be performed at home, in a hospital, in nursing, assisted care. Any setting is fine for palliative care. Whereas hospice care is usually a place you would call home for the duration of your life. It can be your home, your assisted living. It could be a hospice residential center. It can be in a hospital, but again, many hospitals really try to have people move toward a more home-like setting. And sometimes they even have a wing in their hospital setting that you might be transferred to. And my final point before I think we have some time for questions is who are the team of people that you should expect to help you with your palliative care? They would include your doctors, nurses, social workers at the setting where you reside or getting treatment, social workers through, for example, the village that you're a member at, any kind of umbrella services you receive from any Department of Aging funded services or wherever you are, any Department of Aging. So any social workers can help you sort of articulate your needs for palliative care, decide what's most important to you, help you weigh your decisions, and then make your decision to communicate with your medical team so they can honor your wishes. For hospice, the same group of people are going to be helping you make decisions regarding your hospice care. Your team will include certainly a doctors, a nurse who may or may not visit you in your home, certainly would be residing or 24 hours available in a hospice residential center, etc. You probably would also want to include a chaplain in your hospice care, if that's important to you, someone of faith. And also dietitians can be included for those issues regarding comfort care, your desire to eat or not eat, and conveying that to stakeholders like your family and friends. So often people are very disturbed when folks do not want to eat or drink. They feel that that's leading to death, even though death is imminent. So that's sort of some of the quick and dirty outline of the differences between hospice and palliative care. And at this point, I don't know who's facilitating to give. Okay, Judy is facilitating questions, and I would be happy to either have people, Judy can read questions as they come in the chat, or people should feel free to unmute themselves. And I'm changing my view now to gallery view so I can see everyone who may want to ask a question.
Thank you so much, Liz. That was really, really helpful and interesting. There's a couple of questions in the chat, but let's start with Marilyn and Patrick. Oh, you're on mute. Marilyn, you're still on mute there. Yeah, okay.
I'm looking at an article from the Post Health section, March 29th, and it talks about that some dementia patients face obstacles getting into hospice. So I wanted to know what your take is on that.
So your question, just to reiterate, is you're recalling an article from the Washington Post on March 29th in the health section, and the gist of the article is some dementia patients experience problems getting into hospice care
because of Medicare rules.
First of all, I haven't read the article, and so I can't comment on it. I wish. The other thing I wish more often than not was I understood Medicare more deeply. I do know that hospice care is covered by almost every major insurance company, Medicare and Medicaid. And that's why it does require that terminal diagnosis. You can remain in hospice as long as your symptoms and your condition continues to decline. Again, people always say to me, but wait, my friend was on hospice and then they didn't die and they stopped hospice. Right. It wasn't that hospice stopped hospice. It's that the insurance stopped paying, because the indicators from the medical professionals were that, in fact, the person was no longer declining. I have a family friend who has been quadriplegic since the age of 13. His expected life expectancy was somewhere in his late 20s. He's now my age, in his 50s. And he has been in hospice 3 times, stabilized, and been removed from hospice, not because he wanted to be removed from hospice, but because insurance stopped paying for it. So he returned to non-hospice care and to the care of his family, where he continued to stabilize. And then when he declined again, he was admitted again. So that's just an anecdote about why sometimes folks are not admitted to hospice, because there is no clear prognosis for 6 months or less to live. That would probably be the first indicator that I would think of, that folks with dementias of all kinds can live for months, years, decades. And so without a clear or clear-ish ability to predict the end of life, insurance oftentimes doesn't cover it. Does that answer your question, Marilyn, or do you have follow-up thoughts? Okay. All right, Judy.
There's another question about, it says, are there any hospice facilities in DC now? And if not, why not?
There are several hospice facilities in Washington, DC. And I don't want to get into the weeds with that, but I would encourage you all to ring me up or to email me at the Capitol Hill Village. Just call the main number as it appears on our website, and you can ask for Liz Gregg, or just say the person on staff who presented at the end of life seminar. You'll get to me, and I'd be happy to talk to you more specifically. But remember, there is both an in-home option and there are residential options as well. And right now, to be honest, I don't know exactly what hospitals are offering hospice care in DC. And that's part of why I don't want to comment specifically, because I know my comments won't be thoroughly researched, and I owe you a full and clear answer. So I'll defer that one with thanks.
I'm going to ask the next question, but also mention that we have guests here from Washington Home who used to run a hospice facility in DC and are now running a foundation and supporting issues like end of life treatment and care. And so if any of them would like, I
would love, if you want to chime in, but please feel free to, if you want to chime in and unmute yourself and specifically answer the question, where can you get hospice care in Washington, DC?
And then hi, my name is Phyllis Dillinger, and I'm the CEO, CFO of the Washington Home, and I'm driving, so pardon me if there's a little noise. I let Tiffany or Shenalyn talk, but basically the one that, we had one for all those years at the Washington Home, and unfortunately we had to close that with the nursing home, but we invested in with Capital Caring, and there is a brand new one that is absolutely beautiful at Sibley Hospital. It's a 10-bed. And so that's the one I know for sure. And sometimes they have scattered beds in the hospitals, just where you were mentioning, but I don't know exactly where they might be.
And I want to do more research for folks. So that's part of why I deferred answering that.
Yeah, great. Okay, well, so there'll be more to come on that. So there was a question here about why, I've heard that the average length of time in hospice is about a week. Is this true, and why does this happen?
That is true. And why does that happen? Because just like me, I called hospice for my mom. I had had a lovely dinner with her the night before. I was imminently due with my 3rd baby boy and was sticking my heels in the ground and not sharing his name because you know how everybody judges the name. And my last comment to my mom before she was unconscious that night as I left the dinner was, and when she had said, I don't care what your father says, you call hospice. And I had a couple days beforehand, and I was confirming that they would start in the morning and that I would arrive out mid-morning to help with that transition and help my father with his inevitable concerns about that. And my last conversation with her was, okay, Mom, okay, I'll tell you the baby's name. And I told her my son's name, which is a long name. Hang in with me, people. Williamson Mulholland Mater. And my mom, with her closed eyes, said, "That's a long name for a little baby." And that was the last thing she said to me when I gave her a kiss. And the next morning when I arrived, hospice was due to start at 9 a.m. At 7:30 in the morning when I arrived, she was already unconscious, and she died at about 11:30 that morning. So why does that so often happen? Someone like me, I'm a social worker, I'm trained, I understand death. It's called denial. We wish so much for our loved ones to have that time to talk with us, to share their thoughts, impart their final feelings and their wisdom. And so often people view it as a last resort, and they don't want to give up treatment. And they sort of drag their heels on planning, and then they only get a few days. And oftentimes we are beginning to understand that there is some relief there for the person who's dying, and they let go. They realize that it's okay. They can be comfortable now. They don't need to try so hard to keep living. They can just be comfortable. And so there's more research on why that happens. But anecdotally for me, it's because of denial from loved ones, not starting the process earlier. And it's also from relief from the individual who's so grateful that they can rest.
And, ironically, I think, we know that actually receiving hospice care, sometimes the relief of some of the symptomatic experience, which sort of, causes its own sort of, inflammation and like other things that are negative experience, actually prolong life. So if people who start earlier could actually live longer. And yet people associate, starting hospice with the end. And therefore resist it. So that it's just sort of an interesting irony. There's a question here for you, Liz. There are
I have one. Oh, may I say one more thing, which is, Judy, you're so right. The relief that comes with symptom relief and stopping curative care is great. And the introduction of stronger, more directed pain-killing mechanisms can actually slow and terminate life. In both situations, my parents were experiencing pain and were on increasingly strong medications, and were finally given, frankly, the death blow dose of morphine. And that was with our consent. With their consent, we understood that administering morphine would probably lead to death. And in both cases, we supported their desire to end in a dignified way on their own terms. So just a little thought. Judy, thank you for pausing. Yeah. I'm ready for the next question.
Okay, so the question is, there are palliative care doctors. Would a primary care doctor need to refer you? Or are there primary care doctors who also, who are, I don't know, is there board certification? Do you know anything about that?
I don't know about board certification, although my best guess would be yes. I can definitely get back to you about that if that person would like to, again, call me at the main number at the Capitol Hill Village or email me, whatever's convenient.
I'm sorry, that was my addition to the question. The original question was, would a primary care doctor need to refer you?
Okay, so the primary care doctor usually does refer. However, you can ask your doctor to be referred. If you're in the hospital and you're experiencing pain, the standard of care now is that you will be referred to someone, whether if you have a primary doctor, a rounding doctor, a hospitalist who is meeting with you. The standard of care is that they would refer you to a palliative care doctor. You can also request that. You can also coach your loved ones to request that. If you are receiving outpatient care, you can request referral to a palliative care doctor who will partner with your doctor. There are special qualifications. Many general physicians or specific physicians will tell you that they can deal with your needs. And if that works for you and you have a good collaborative relationship, fine. If you would really like to have a specialist look at your situation and speak with you, insist upon it.
I think as you were suggesting that there, so much of this is driven by Medicare, right? There's really no reason why, more palliative and curative care can't go hand in hand. People being part of the reason why people go to hospice so late, I think, is that they're forced to choose. They're forced to choose to discontinue, curative care, which is,
Right.
you know, which shouldn't be. You shouldn't need to have to give that up in order to be comfortable. But that's a whole other area of advocacy, I think that folks are involved in and maybe need to do more. There's a comment here in Phoenix. There's a wonderful nonprofit organization, Hospice of the Valley, that has several lovely inpatient. Oops, it just. Sorry, my screen is. That went away.
Can hear you just fine. We can see and hear you just fine, Judy.
Yeah, no, it says it has several lovely inpatient standalone hospice facilities. It also provides in-home hospice care. It would be great to have such a hospice here.
That really dovetails very well with the question before the last, which was pertaining to, are there residential locations in Washington, D.C.? And I could hazard a guess and throw out a couple names, but I don't trust myself to know what's most up to date with so many changes in healthcare, with challenges regarding funding, being overwhelmed with the pandemic. There have been enough changes that I don't feel confident saying the exact names, but I know that that information is crucial and I can address it and would be happy to get you those resources. But to share just sort of my impressions or my overall thoughts right now, I don't think would do any favors to anybody. I'd rather have you have the best and most current information.
You know, I think this might be a good article for our CHB newsletter. You know, we can get immediate answers to folks who are interested in just having lists, but I think this might be a good article for for an upcoming newsletter.
I think it's a great idea.
Any other questions, folks? Any other questions about palliative care, hospice? There was one thing, Liz, that you said you were going to address. I think it was about the MOST program in DC.
Thank you. Yes. Yeah. So one of the things that people get very confused by is the differences between various forms and directives pertaining to end of life. And again, I think we're going to dig into that much more deeply. We really will be in the weeds together when we reconvene in June for part 2. That will dig in much more deeply about the specific forms, the specific directives, legal versus personal directives that are needed to create and plan a dignified end of one's own life and one's loved ones and communicate. So they're all different forms. Some of them that have been mentioned during the course of this past session or this day-long seminar are MOLST, the Maryland medical directives. 5 wishes was mentioned by somebody earlier. Healthcare power of attorney, that is different. Your will is also different. All of these things, and again, I am not a lawyer, so I don't speak about things I don't understand and know, but I do know that we can get you that most specific, up-to-date, and accurate information about these kinds of documents. MOST is something that is legally binding. It's sort of interchangeably thought of as a medical directive, and there are slight variations. We will have much more detail in our second part of our seminar because I think we're actually going to have an hour-long session. And Susan, I see you, Mary. Can you nod if I got this right? Okay, we're going to have much more detailed information about what each of those are, how they vary, and how to make them sure that they're legally binding and that your wishes are reflected in them. So instead of digging in there, do you want to say
I just want to say, so the MOST program in DC only started a few years ago. And actually it was DC Appleseed, which is my former organization, that actually was the leader behind that. And really the reason that it was started was because it is a medical order. There's been some people have found that, you know, they do a legal advance directive, but it's not at the hospital where doctors are going to see it, or doctors kind of need to see it, and hospital staff need to see it in their language, in their format. And so that's what the MOST form does for you. It's not, it can be supplemental. It can be, you know, it's not an either or, but it is designed to speak directly to your, the medical personnel who are caring for you, including EMTs, and, you know, and other healthcare providers. So that's something that, you know, that if you're concerned about that, you know,
Judy, can you spell it?
Yeah, it's medical. Well, they're called different things. In DC, it's called MOST, M-O-S-T, just like that word, and it stands for Medical Order for Scope of Treatment. And the Department of Health is, you can find, there's a website. We'll share that around. Is one of the things that we'll share around. I think we may even have it on the, it may even be on the supplemental materials that you've got, but we'll make sure that you get that. But that's a document that goes into detail about what kind of, you know, what kind of treatment you want in case of, you know, do you want like CPR, for example? Like people think, oh, CPR, that's pretty natural. But in fact, you know, once you learn about it, you realize like CPR actually can break your ribs, that most doctors wouldn't choose to have CPR if they were, you know, if they needed to be resuscitated. So things like that. There's a lot to that, but it's really talking to the doctors in their terms and in their language that they feel more bound by it.
Right. And I just want to also add, our over at the Capitol Hill Village, our wonderful Mary Bloodworth has dropped into the chat a link to the DC MOST. And so if you know how to find the chat, along the bottom, there's a little sort of thought bubble, the word chat underneath it. If you click on that and you have to scroll down, it should open up right to, it says Mary Bloodworth CHV to everyone. And if you push that, it will take you to your browser and open up the MOST. Okay, I was actually just speaking with a Capitol Hill Village member who has an advanced power of health care directive. Her sons serve as her healthcare power of attorneys, and she's having a relatively minor procedure done, but it will be under anesthesia. And in addition to bringing along her Advance Care Directive, she is filling out a MOST form, and we work together on reflecting her desires, given her good health, her intent that this is a minor surgery and that she will live for a long time after this with improved functioning, that she has a MOST that she wrote just for the purposes of this in and out day surgery. And at the end, she's going to rip it up, and you know, when she's back home and safe, she's going to rip it up and defer back into her other legal binding documents. It's really something that's a tool for you, as Judy said, to bring with you for medical treatment as sort of a cheat sheet for doctors, nurses, family, if there should be something that occurs. It can also be your document and be legally binding, but my point is it can be used flexibly to serve your purposes at the time. Judy, do we have another question before breakout?
One more question. We're going to go into our breakouts in just a second, but before we do that, somebody wants to know how you become a certified death doula.
Sure. I did research. I had completed my coursework as an end-of-life social worker. I had, of course, been very interested in the whole idea of birth doulas. I never used one myself, and decided that I really was ready to be involved, deeply involved in the process of someone's life ending, helping them decide that. And so I did a lot of research. There are a variety of certificate programs online. I don't recommend them. With this kind of work, I think it's very important to actually do the work in person if possible, or in the most intimate way via Zoom, but an online certificate is not going to prepare you. I chose to go with an organization called INELDA. I'll put it in here, and maybe somebody who can look it up. Okay, I put it in the chat. It's called INELDA, and it is a training. It's a an international organization to support the work of death doulas, to provide comprehensive training and resources about the process of death and dying. I found the training wonderful, challenging. Thank you so much, Megan, for adding that into the chat. Again, if you click on that link that Megan just put in the chat, it'll take you straight through to the ANELDA website. And so I chose that training. There were people in my training who did not have a background in social services or mental health care. And I think it was a lot more difficult for them. I was already 25 years into my career as a social worker, and I found it to be a wonderful adjunct to what I kind of already knew and practiced. So I do recommend that it be used by people who really have more experience with talking about these kinds of difficult topics and or being present for loved ones, family, friends who have died, who really are there emotionally. I think it was very hard for people who did not have experience with death and dying personally or did not have professional training regarding it.
Great. Thank you so much, Liz. That was really wonderful. Oh, wait, I saw it. Anne? Let's make this the last question because we want to do the breakout rooms too.
I just wanted to comment that you wanted to know about board certification for palliative care doctors. My daughter-in-law is a board certified palliative care doctor. She works out of Temple. She has a team of 5, 2 nurses and 2 social workers who work for her. And she was board certified first time they offered the test was about 9 years ago.
Great. Thank you, Anne. That's really helpful.
Wonderful. Thank you, Anne.
Well, thank you, Liz. That was tremendous and really an incredible addition to the conversation that we've been having today. And Mary is going to send us back into our breakout rooms where we'll have a little bit of an opportunity to process some of this and also talk a little bit about part 2 coming in June.